Well, hello, everybody. I'm Peter Stotz. I'm chairman of the Vagus Nerve Society. And I'd like to begin by thanking my friends from Spark Biomedical, Dan Powell and his entire team for supporting this educational webinar on the vagus nerve and addiction. I'm thrilled to have Drs. Kovalin and Dr. Kataparast, who are the co-founders and Chief Technology Officer and Chief Science Officer, respectively. Both of them here to help us explore the neuroanatomy of the vagus nerve, auricular branches of the vagus nerve, and the clinical applications in addiction. Our intention here at the Vagus Nerve Society is to inform and inspire, particularly those with an interest in the function of the vagus nerve and how it helps in both wellness and well as in disease. We further want to cross-fertilize areas for people who are interested in one area to help them understand various aspects of vagus nerve stimulation, and how they may be able to apply it to new areas, further blossoming our field. In December, we had an outstanding discussion with two leaders in the field of threat in the vagus nerve, Dr. Steve Porges of the polyvagal theory and Dr. Doug Bremner from Emory University. We have plans for expanding our content to include topics such as the gut microbiome, headaches, abdominal pain, and how the vagus nerve can help that, bleeding disorders, enhanced cognition, nutraceuticals, anxiety, stroke, in various upcoming webinars. This will be a wonderful opportunity for us. Tonight's webinar is particularly interesting to me, assessing the role of the vagus in opioid addiction. I have been a pain physician for over 30 years now, and throughout this time period, I've grappled with the competing issues of pain and addiction in my clinical practice. Here in the US, we spend over $700 billion in both lost productivity and the treatment of addiction. Having a strategy that is something other than let's just give more opioids to a patient is incredibly important, and at this particular time. I've previously described the two competing interests of chronic pain, which costs the American people more than cancer and heart disease, and addiction as kind of two I don't know, the yin and the yang of top issues around healthcare. I look forward to hearing from these two experts about this disorder tonight. Dr. Kovalin, with nearly 3 decades of device development and a deep focus in the medical sector, holds a degree in physics engineering and a master's and PhD in biomedical and neural engineering. His specialization lies in neuromodulation techniques, particularly in modulation of the autonomic nervous system. As a prolific inventor, Dr. Kovalin holds multiple patents showcasing his innovations contributions to the field. Collaborating with a diverse range of organizations, he has played an important role in developing groundbreaking devices and therapies for medical conditions, including obesity, hypertension, pain, diabetes, migraine, depression, and substance abuse disorders, all with the intention of enhancing patient outcomes. He will be discussing an understanding of the neuroanatomy and physiology of auricular neurostimulation. Dr. Kataparast is a well-known researcher in the field. He has a PhD in neurophysiology and his focuses on the vagus nerve and vagus nerve stimulation to promote restorative brain plasticity and to treat neurologic disease. His research is considered foundational for the principle of targeted neuroplasticity training and has led to multiple VNS trials for stroke rehabilitation. He's a scientifically driven entrepreneur and is involved as a PI or MPI on multiple NIH and DoD funded studies. He has co-founded and serves as Chief Science Officer for Spark Biomedical, where he's responsible for seeing Spark's clinical initiatives. He works to advance the technology into potential new indications as well. He will be discussing the clinical applications of auricular neurotherapy in patients with opioid dependence. With that, I'm going to turn it over to Dr. Kovalin to start our presentation tonight. Thank you very much and look forward to an exciting discussion.
Well, thank you very much, Dr. Stotz, for the warm welcome and very nice words. Thank you for everyone for being here. We're very excited sharing with you this information. So thank you very much for being with us tonight. As Dr. Stat mentioned, we divided this talk into two parts. I'll talk about the neuroanatomy, neurophysiology of the auricular nerves. I will talk about downstream and upstream pathways. We'll talk about the nerve types, which is very important when you're producing a neuromodulation device. And to that end, I'll talk about the stimulation parameters and how they affect the therapy that you're trying to implement. Let's first talk about the nerves that are around the ear. We have in front of the ear, you have the auriculotemporal nerve, which is part of the trigeminal, right here in the front. And we also have, there it is, the auricular branch of the vagus nerve right there. And we have also on the back, we have the great auricular nerve, which is part of the cervical C2 and C3 branches. And of course, we have also the posterior auricular nerve, which is part of the facial nerve right there. So as you can see, you have multiple systems here. You have the trigeminal, you have the vagus system, you have the facial nerve, you have some cervical nerves, and as I will talk about in a second, you also have the glossopharyngeal nerve involved here. Some fibers come here. To this discussion, I would like to add, I've been asked several times if we consider auricular neuromodulation the same as cervical vagus. Clearly, it's not the same. However, there are many aspects and many therapies that could benefit from both techniques. So I just wanted to point that out there. Let me move on to the next slide here, talking specifically about the auriculotemporal nerve. This nerve is, as I said, part of the trigeminal system, part of the mandibular branch of it. The superior part of it, which is the interesting part for us, contains mostly somatosensory afferent fibers. It also connects to the facial nerve and to the glossopharyngeal nerve. In particular, it connects to the facial nerve as they both meet in the geniculate ganglion, and with the glossopharyngeal nerve at the otic ganglion. So these three nerves have some connections. Now, talking about the vagus part, the auricular branch of the vagus nerve, I just wanted to show you how the vagus, the auricular branches off the vagus, the main vagus nerve here. It comes out of the superior or jugular ganglion, and it travels through the what is called the Arnold's canal, or the mastoid canalicus, as it surfaces from the skull into the tissue close to the surface. It is also connected to the posterior auricular nerve. I'll show you here in a second, which is part of the facial. There it is. That's the auricular branch. That is part of the facial nerve right there, and they're basically connected to each other. And if we follow the auricular branch of the vagus nerve in, let me show it here. There it is, the auricular branch of the vagus. That's the facial. And if we follow it inwards, you'll see that it is connected right here to the glossopharyngeal nerve right there, and of course to the vagus. So interestingly, you can see that there's almost a loop being formed between the trigeminal system and the vagus, going into touching the nerve, the facial nerve, as well as the glossopharyngeal nerve. It is important to point out that as the auricular branch of the vagus nerve, or ABVN, surfaces, it is composed of about 20, well, let's say 10 to 30% of alpha or A beta axons, which is very important in, again, determining the type of stimulation you use, in particular the pulse width. I'll talk about it in a second. And it is also very important to note that these type of fibers are the most likely fibers through which we are providing the therapy that we can see. Here I wanted to show you the upstream pathways. This slide is showing activation of the auricular branch of the vagus nerve, or stimulating the auricular branch of the vagus nerve, specifically at the Simba concha. And you can see activation of very important and interesting regions of upstream, such as the nucleus tractus solitarius, NTS, the spinal trigeminal system, the raphe nucleus, which of course produces most of the serotonin, the locus coeruleus producing most of the norepinephrine in the central system. We also see the accumbens, the amygdala, the periaqueductal gray area, which produces a lot of enkephalins, and others. There is also very likely an activation of the arcuate nucleus in the hypothalamus, which is strongly connected to the NTS. In fact, it has most of the extra hypothalamic connections going into the arcuate comes from the NTS, and that's very important because the arcuate nucleus is the main producer of beta endorphins in the central nervous system. Now, let me point to your bottom left graph. That's a time line of stimulation. An important point to make here is that, as you can see in this graph, after stimulation, the areas remain active for several minutes. And that is important, again, when we are delivering the therapy, to understand how long we need to start and stop the therapy for several reasons, which I'll go into in a bit. But the take home is that you activate, and they just, when you turn off, they don't just shut down, they remain active for several minutes. Now, talking about the descending pathways, we all know the vagus nerve touches a lot of organs as it goes down. Just to name some: the heart, the lungs, the liver, stomach, the intestines, spleen. That indirectly, of course, through the splenic nerve. And here I wanted to show, in the past slide, we talked about the upstream activation of activating the vagus nerve, specifically from the auricular area. And here I'm only showing the pathways that we all know that exist, but I want to show you some examples of trials, all of these randomized control trials activating the auricular branch of the vagus nerve. I'm just showing examples here, 3 that are based on ascending pathways, 3 that are based on descending pathways. The point is that you're activating both the descending and the ascending pathways. Likely, the descending pathways are being activated not directly, not retrograde. We don't have full proof in humans, but I think it's actually going through the ascending pathways and then down. So here we have the 6 trials that are very interesting, based on ascending pathways. There are cognitive trials, specifically this one for mild cognitive impairments, in which 24 weeks treatment showed very significant results. There is the second one here for stroke recovery. This was a periplasticity study where movement was used to trigger the stimulation. And here again, in 12 rehabilitation sessions, they show very promising results. Depression, there's been a lot of trials for depression. Here I'm just pointing out to a meta-analysis of randomized controlled trials, again showing very good results in a large quantity of subjects. Descending pathways, there are trials for AF, atrial fibrillation, showing again very good results of reducing the AF burden. We have also trials for gut motility, using real-time MRI to show the gastric motility. And here there is a very interesting aspect that I want to point out, which they tried with low frequencies and medium frequencies, and only the medium frequencies worked. And this is a very important point, because frequency is qualitatively different than the other stimulation parameters, and I'll talk to it in a second. Then the last one that I wanted to point out has to do with inflammation. This was done in hospitalized COVID-19 patients. Therapy was delivered for 90 minutes for 7 days, and they show a reduction in IL-6 and C-reactive protein. So again, I just wanted to show the effects that you can have both ascending and descending by activating the auricular branch of the vagus nerve. Here, I wanted to talk about the stimulation parameters. Many of you might be familiar with this or not, but I think it's very important to point this out. Like I mentioned before, there are some what I would think or what I would call qualitative and quantitative stimulation parameters, being the quantitative ones, mostly the intensity, the pulse width, the distance to the target, and the waveform to some degree. And I'm calling them quantitative because if you stimulate more, you'll probably reach the threshold. If you haven't, while the qualitative ones play the system itself that you're trying to stimulate played a very important role in determining which, like the frequency or duty cycle. Intensity, there are two ways to stimulate electrically. When we're talking electrically, you can do what they call a voltage control stimulation or a current control stimulation. The main or the only advantage of the voltage one is that is a simpler circuit and is much cheaper to produce. But in reality, you cannot know what dose you're delivering when you use a voltage control. And dose in this scenario is basically the quantity of electricity or the quantity of charge you push in. You can only know how much you really push in if you use a current control system, which is pretty much independent of the impedance of the skin. And this is particularly important when you're doing transcutaneous stimulation. The pulse width it plays a role in selecting the fibers that will reach threshold quicker. In particular, larger axons will need shorter pulse widths to reach threshold. The distance to the target, again, very important when you are far away, like a transcutaneous application, instead of having a cuff or a different when you're very close, like a percutaneous electrode. This is very important when you decide how far apart and where you put your electrodes. Of course, one being active and the other one the return. And these three parameters, the intensity, pulse width, and the distance to the target, are interdependent, especially, to reach a threshold. I'm showing you here a graph that many of you might know, which is the dependency of reaching a threshold between the current and the pulse width. It is, most people call this the strength duration curve right here. And just showing you this relationship. And then, of course, once you reach threshold, that is a threshold at a particular distance to the from your electrodes. And of course, you need to increase the intensity to reach further out. Waveforms, there are many different waveforms. I'm only going to talk about square or quasi-square waveforms. And I'm qualifying them into three aspects of them: the activation, meaning how easy it is to activate; the tissue damage, how much you can damage; and then the electrode corrosion, or how much you will damage your electrode. The first that I'm going to point out is the monophasic. We only have one pulse. That reaches activation very easily, but tends to damage the tissue. And that damage comes in the form of pH imbalances. And then you have the biphasic imbalance, which a lot of people like to talk about. But of course, you need to know, and that is supposed to help you mitigate irreversible electrochemical reactions. But of course, to hunt it down, you need to do trial and error to really know what you need to do with that imbalance. The most used one, I think, is probably the next one, the biphasic balance, where you inject the same amount of charge that you pull. But it is hard to reach activation. You need a higher amplitude to reach the activation of the nerves, which brings us to the next one, which is my favorite, the biphasic with an interpulse interval between them that allows you to reach threshold much easier. I believe is a nice balance between the three aspects, especially since we are doing transcutaneous activation. So tissue damage is not that big of an issue because it's not a chronic application. And we have not seen any damage in the tissue in our application. The next one is biphasic asymmetric, where you make a very long return that tends to not recuperate all the reactants in the electrochemical reaction. So it tends to damage the tissue, but it saves the electrode well. The next one is also very, very used, is these asymmetric with an exponential decay. That is very good for the tissue, but is very bad for activating. Those are the quantitative, I would say. The qualitative ones, I think the most important one probably is the frequency. And the frequency, if you think about the system, we have multiple synapses along the way. So you basically have a chain that goes from electrical activation to chemical activation to, again, electrical activation and chemical activation. So you need to find the right frequency to maximize the output of this network. If you go too fast, you're going to deplete some of the vesicles in some part of along this line, and basically not going to get the best output. If you go too slow, you don't get the maximum output. So that's why frequency is a very important qualitative parameter, that it needs to be tuned to the specific network that you're trying to activate. And we actually stimulate at different frequencies the vagal system and the trigeminal system. Then the duty cycle meaning how much you have your stimulation on and how much it is off, and how you repeat that. This one is also, I would say, network dependent, and in two ways. Physiologically speaking, you can have an accommodation very close in the first synapses, where you eventually accommodate the tissue to the response. So you start responding as fast or as easier. But you also have an accommodation, or what I would call an informational accommodation. And that is an interpretation in the brain, where if you have the same signal and is very predictive, the brain is very fast to understand and find patterns. And if there is something that is very repetitive and you know when it's going to happen, it carries zero information. And if it carries zero information, you risk the brain will start paying attention to it, and it won't react. So it's also very important to know what is your target. For example, wakefulness, it's been or attention has been discussed a lot about using short bursts instead of a long activation period. Us, as Navid will probably, Dr. Knapros will point out, we, for opioid addiction, we use a longer, we turn on the therapy for 5 minutes before we turn it off, and then on again, etc. With that, I don't know how much we're doing in time. Oh, just wanted to mention this very quickly. We have been approached by many researchers asking us to help them with some aspects of investigations or research projects that they have. Of course, we cannot do all, and we're trying to help everyone, the entire society, working on activating the trigeminal or the auricular, doing auricular neuromodulation. So we produce this research unit where you can basically change anything you want. You can trigger it to do perplasticity. You can have APIs to basically program activation, etc. So this is, I just wanted to mention this very quickly. This is available for researchers. So if anyone, just contact us. And with that, like to turn this to Dr. Kadaparas. Thank you.
Thank you, Dr. Kovlin, and thank you, Dr. Stotts. And I also want to say thank you to the Vagus Nerve Society for allowing Dr. Kovlin and I to share some of the activities that we've been doing at Spark and some of the clinical initiatives that are occurring. And I want to say thank you to the audience and good evening. Okay, so I just wanted to give a very brief overview of how opioids affect the brain. As we know, there are various forms of opioids, and obviously there are exogenous opioids. These are opioids that come from outside your body and then enter your body. And as we all know, there are many different opioid receptors throughout the body. So there's some in the spinal cord, there's some in our periphery, but there's also some in the brain. And so when you think about substance use disorder and opioid use disorder, a lot of times we're thinking about the reward network and how that can be hijacked by an opioid and how that can lead to opioid dependency and eventually an addiction. But if you think about the pathway of the opioid and how it makes its way into the brain, there's a very specific area of the brain called the ventral tegmental area that's of interest. Why the VTA? Because it's an area that is responsible for the propagation and release of dopamine, which is then captured by the nucleus accumbens, and that leads to intense pleasure. And this is kind of the rewarding behavior and this kind of sensation of satiation that leads people to kind of want to take opioids on a repetitive basis. And so we also thought that this would be like a linear function, meaning that the more opioids you take, the more pleasure you would get from them. But as we all know, the brain is plastic. This is actually quite the opposite. It doesn't actually have a continued effect over time where you get pleasure from it. The brain starts retrieving these and retracting some of these dopamine receptors, which then requires you to take more of it, and that leads to a dependency and an addiction. And so this is actually a really great study that I became a fan of, especially because this is from Dr. Nora Volkov. She's the director of NIDA, the National Institute of Drug Abuse. And this is a way of showing how prolonged use of opioids, or excuse me, of substances, in this case methamphetamine, can change your brain and lead to not only a structural change, but a functional change. And so this is a neural imaging technique called positron emission tomography. And what you can see here are two brains. On the left, you have a healthy control brain, and then on the right, you have a drug-abusing brain. The drug abuser in this case is methamphetamine, and the kidney shape, these kind of like heat-mapped kidney-shaped regions, is the dorsal striatum in the brain, which is typically has a very high density of dopamine D2 receptors. And so you can see in the healthy brain, in this heat map, the more red area showing high density. But if you look over at the drug-abusing brain, you can see there's a marked difference in the amount of dopamine D2 receptors. And so what this tells us, again, is the brain is plastic. Over time, with prolonged drug use, the brain will start retrieving and retracting these dopamine receptors, thus requiring you to take more of the substance to get the same effect. And so this is a really beautiful and simplistic way of showing drug tolerance. So for patients that are suffering from substance use disorder, in this case for opioids, there's something that is called the withdrawal barrier. And so if someone is wanting to taper off or reduce the amount of opioids, unfortunately, these patients will experience withdrawal symptoms. And you can see some of these symptoms listed here on the right. And depending on the type of opioid, whether it's a short-acting opioid, such as heroin or fentanyl, or a long-acting opioid like methadone, the onset of withdrawal symptoms can vary. It can be from 6 to 12 hours, even to 24 to 48 hours. And how long the withdrawal symptoms persist can also vary. So in a shorter-acting opioid like fentanyl, we're seeing around 7 to 10 days, whereas longer-acting opioids like methadone, again, this can be it can be several weeks of where they're experiencing acute withdrawal that can lead to protracted withdrawal. And what we've heard from our patients is that the two most common withdrawal symptoms are pain and fear. Pain meaning if you speak to an addiction specialist, a lot of times they'll say it's the worst flu that a patient has ever felt, or their bones are on fire or boiling. And obviously their fear of withdrawal is really what drives them to have this drug-seeking behavior. They're always running away from withdrawal. because they feel like they're going to die from it, even though it is one of the only substances where you typically do not die from experiencing withdrawal. Now, there are many different pharmacological treatments available for opioid withdrawal and for the treatment of opioid use disorder. These are called medications for opioid use disorder, or MOOD. And there's varying forms of them. Methadone was one of the first ones that was established and created. Methadone is a full agonist. It binds to the mu opioid receptor in the brain and allows you to reduce the amount of withdrawal and then maintain a long-term treatment. Buprenorphine later came, and this was kind of a revolutionary drug in the sense that it's a partial agonist, meaning that it has a mu receptor agonist and it also has a weak kappa opioid receptor antagonist. And it's also been shown to have a delta opioid agonist as well. So it's kind of a combination partial agonist and antagonist. There's also an antagonist medication called naltrexone. There's oral naltrexone that's been used for alcohol use disorder, and then there's injectable naltrexone for long-term management, where patients come and get an injection. It can give them, will block the mu and kappa receptor for roughly 30 days, and then they come in repetitively to get the shot. That way, if they take any opioids, they don't really get any of the effect of the opioid because of this antagonist medication. And in 2018, there was a very revolutionary drug called lofexidine that came out. This was the first non-opioid pharmacologic to treat opioid withdrawal. And as you can see here, this has a different mechanism of action. It's an alpha-2 adrenergic agonist, and so it binds to receptors in the locus coeruleus. And so as you go through withdrawal, the LC is typically hyperactive, and so lofexidine's role is essentially to kind of reduce the firing rate of the LC and then help relax the patient into a more subdued state. There are some concerns with it. Lofexidine does have a side effect known for bradycardia, or excuse me, hypotension, so low blood pressure. And so a lot of patients feel that effect, and they kind of go a different direction in their treatment plan. But obviously for today, we're really trying to focus on neuromodulation. And so how does this method play a role in addiction treatment, specifically with opioid withdrawal? And so this was a study that I found that was very interesting to me because it was published in 1992, so a little older study, but it was in Nature Physiology. And why I like this trial was the fact that it really showed that neuromodulation has a role in promoting endogenous opioid release. And so endogenous opioids are essentially opioids that we make ourselves. They're also known as endorphins. And endorphins, or these endogenous opioids, bind to the same opioid receptors. For example, the mu delta and kappa receptor. And so this study was in animals, was later translated to in clinical trial. But essentially what they were trying to show was that by delivering neurostimulation, not only can you increase the level of endogenous opioids, but importantly, it was frequency dependent. So as Alejandro earlier talked about frequency and its importance, we're really able to see it here in this trial. And so you can see in the bar graphs here, you have the enkephalon neuropeptide class, and then you also have the dynorphin. And the enkephalon seemed to respond more favorably towards the lower frequencies, where the dynorphins respond to higher frequencies of stimulation, respectively. And so they kind of put this in a little flow diagram on the right, where you can kind of see how the different frequencies releases the different types of endogenous opioids and where they bind to their respective opioid receptor. And this was a pain trial, and so they really wanted to emphasize that how it could help with anti-nociception. And they gave some hypotheses as to lower frequencies activate the arcuate horn, whereas the higher frequencies activate the parabrachial nucleus. And these have descending pathways down into the spinal cord to help with pain mitigation. Well, those are older studies, and we've really started to understand pain and the ability to release these endogenous opioids. And so the technology that Spark created is called, or at least the method is called Transcutaneous Auricular Neurostimulation, or tAN. And as Alejandro stated earlier, there is a difference between cervical vagus nerve stimulation and auricular vagus nerve stimulation. And since we're really not targeting the vagus nerve or the trigeminal nerve in particular, we're targeting the synergistic application of multiple cranial nerves. And so that's really the culmination of this technology, is looking at how we can bring in different nerve types and potentially enhance our signal and optimize therapy for our patients. And so in terms of the device, it's quite simple. It has a patient controller, it has a cable, and then it has a disposable earpiece. The disposable earpieces use hydrogel technology to be able to activate the nerves underneath the skin. And so you can see we're targeting specifically here with these two electrodes, region 1, which is the auricular branch of the vagus nerve, and region 2, which is the auricular temporal nerve right in front of your ear, which is a branch of the trigeminal. And then we have a return electrode behind the ear, allowing us to do biphasic neurostimulation. And so the idea is, regarding how this works for opioid withdrawal, is the fact that by activating these two nerve bundles, right, the ABVN and the ATN, they're sending signals into the CNS, specifically through the medullary region of the brain, activating the nucleus tractus solitarius, and then these have projections into the reward network. So we can start modulating the ventral tegmental area, the amygdala, nucleus accumbens, arc, and so on and so forth. By activating some of these nuclei, we believe that we're able to release endogenous opioids. So as a patient is tapering or coming off of an opioid, and these vacant opioid, the opioid receptors are vacant, we're able to fill them with the patient's own endogenous opioids, thus reducing withdrawal symptoms. The other aspect that is interesting in terms of the mechanism is that since we are activating vagal networks, it is very much known that the vagus nerve is a promoter for parasympathetic activity. So as patients are experiencing opioid withdrawal, they're experiencing not only withdrawal symptoms, but they're experiencing heightened sympathetic drive, such as it's an imbalance to the autonomics. So by enhancing vagal input, then we can promote parasympathetic and hopefully reduce the patient's withdrawal symptoms and restore autonomics. And so now I'm going to kind of shift gears and talk a little bit about some of the clinical initiatives that we've conducted with this technology. And so this was an FDA clinical trial that Spark sponsored to be able to get our first device on market and FDA cleared. And so this trial had a principal investigator by the name of Dr. Carlos Tirado, great colleague. He's an addiction specialist and psychiatrist. And we targeted 20 to 40 patients with opioid use disorder in an inpatient treatment facility. And you can see here, Karma Health and Recovery Unplugged in Austin, Texas. It was 5 days treatment with no opioid medication. So patients were only allowed to have comfort meds, no buprenorphine or methadone was allowed. And we really the study was geared to show, can the device reduce opioid withdrawal symptoms quickly? So within the first hour was our primary endpoint. We had to show a clinically meaningful reduction in the COWS score, which I'll talk about in a minute. We also looked at a few other neuropsychological outcomes regarding depression and PTSD. So here are the results from the trial. To just orient you to figure, the mean COWS score on the is on the y-axis. The COWS is the clinical opioid withdrawal scale. It's the gold standard in terms of measuring withdrawal symptoms in adults. Patients had roughly a 15, which puts them in moderate withdrawal. So they're experiencing a lot of GI distress, trembling, anxiety. There's aches and pains. And you can see here, after just 1 hour of stimulation, we had about a 45% reduction in the withdrawal. So almost half of their symptoms were dissipated in just 1 hour. And then following that, as they continued their inpatient treatment through days 5, you can see that we continue to reduce their withdrawal over time and maintain a good level of symptom mitigation. So we did look at the depression scale, the PHQ-9, and also the PCO-5 for PTSD, and we saw very favorable results. We saw roughly about 42% of our patients had clinically meaningful reduction in depression scores after just 5 days of treatment, and also over a third had clinically meaningful reduction of PCO-5 at day 5. So after this first study that Spark conducted, we really wanted to start expanding our indications. And so this is just a few of the studies that we've been able to submit data for as preliminary, and then gather some NIH funding and also DoD funding. And so for the next slides, I'm just going to be talking about just a few of these studies that are ongoing, or one that was completed, and then the rest of them are ongoing. And so The study that we did complete and publish was in a very special and vulnerable population that's unfortunately part of the opioid epidemic, which is infants that suffer from neonatal opioid withdrawal syndrome, or NOWS. This was a study that we conducted at MUSC with Drs. Bashar Badran and also Drs. Doe Jenkins, a neonatologist. And it was the first study ever to really explore how neurostimulation could help reduce withdrawal in infants. And so in this first in human trial, really what we wanted to show for this is that can we reduce the amount of oral morphine? So as babies that are typically born with NOWS, if they require pharmacological treatment, in some cases they put them on oral morphine, which is an opioid, and they slowly wean them off. And so what we were able to do in this study was essentially, you can see in the blue line here, was that when they started taking oral morphine, and then over time, as we delivered just 30 minutes of stimulation prior to each oral morphine administration, we can reduce the amount of withdrawal, and thus we can wean the infant off of morphine quickly, as opposed to a longer weaning timeline. So just if you look at the national average, it's usually around 23 days. Whereas in this study, it was the median was 9 days across 8 infants, and while just with the device was 6 days. Now, this study has the limitation, obviously, being it's an open label trial, and also it has a small sample size and it was not randomized. And so we really wanted to explore further in that direction. Here are 3 ongoing clinical trials right now that are being conducted through NIH funding. And so one is called the RESTORE study, which really allows us to expand our first adult study, which was just a 5-day inpatient treatment. The RESTORE trial goes beyond that. We still treat opioid withdrawal symptoms inpatient in a 7-day program with our partners at Hazelton, Betty Ford, and Gadenzia. But also we look at the long-term recovery. So we're looking at treatment retention and opioid craving mitigation, and also looking at depression, PTSD, and anxiety over time. And so this is a study that should be wrapping up hopefully this summer with over 100 subjects in the trial. The SPROUT study is a continuation of the first neonatal study we conducted. This is an FDA trial looking at to see essentially a randomized control trial with 3 different institutes, UT Southwestern, UT Health, and MUSC, and really trying to see if we show favorable results, we can bring this product to market and start helping the lives of infants suffering from NOWS. And then last is Tandem, which is a collaborative study. It's through an RM1 project through the NIH. It's an interdisciplinary trial with 2 different institutes, UTMB and MUSC. And it's the first brain imaging study to look at both vagal and trigeminal neurostimulation on its effect on pain. And so there have, as Alejandro showed in his slides prior, there have been many different studies looking at the auricular branches of the vagus nerve and the activation profile in the brain via fMRI imaging. But there has never been a study that has looked at 2 inputs of 2 different cranial nerves at the same time. And so that's really kind of what this study is geared at. And so I'll kind of go a little bit further into Tandem. And what you can see is that we have really broken this study up into 3 different projects. And so the first project is to evaluate the specific role of endogenous opiates as an underlying TAN-based analgesia. And so this is a way for us, and this is being done in healthy individuals, but it allows us to look at the brain activation and pain thresholds that will be assessed following auricular vagus nerve stimulation and trigeminal nerve alone, so individually, and also the combination of the 2 nerves. And in terms of pain, this will allow us to understand the mechanism by using a experimental form of a mu receptor blockade. So essentially using naloxone blockade, which, as you can see in the image here, when we block the receptor, we can understand further if TAN is actually having a modulatory effect on these mu receptors. The second project allows us is a more classical imaging study where we just target either the ABVN, the ATN, the combination, or a sham, which is the earlobe, and we just stimulate these different conditions And while the patient is in the scanner, they're wearing the earpiece, receiving the stimulation, and we're just passively recording and looking at the different activation regions of interest in the brain. And then the last project, the first two are both in healthy human subjects. The last project is in chronic pain patients. So they come into a treatment facility at UTMB. They go through 4 days of opioid tapering. So they're coming off of their opioids. We do a baseline imaging scan to see how their brain looks while they're in chronic pain. And then we taper them off for 4 days using the device, so helping with juice withdrawal. And then at the conclusion of the 4 days, we do a post-tapering brain image. And we're really trying to see, is there any changes to the brain that can occur in this acute phase of opioid tapering? And I do have some preliminary data from Tandem that I wanted to share today. And this is blinded data. And so this is from Project 2. So this is where subjects are going in the scanner and receiving 4 different conditions. And you can see here, these are the 4 conditions. They're obviously coded, so we don't know which group is which. But what we're able to see, and you can probably see this as well, is that there are distinct patterns here. It seems to be 4 distinct neural signatures, and this is cortical fMRI scan for right now. But what you can see is that there are differences across these 4 different conditions, which is interesting because it does tell us that if you stimulate just one nerve, you get one pattern. If you stimulate 2 nerves or a different nerve, you may get a different pattern in the brain. And so this could potentially lead to treatment optimization. We could look at synergistic profile, potentially antagonistic profiles. And we're just getting a better understanding of how these cranial nerves can function together. And so I believe I'm going to conclude there. And I want to say thank you very much. It's been a pleasure.
Wow. Well, thank you, Naveed, and thank you, Alejandro, for very enlightening lectures. While Alejandro is having a beer and trying to figure out how to come back. Oh, there he is. Good to see you, my friend.
Yeah.
I have a couple of questions for you. And first of all, let me just say thank you to everybody who participated in this symposium tonight, in addition to Alejandro and Naveed. I looked at our list of participants and saw people from all walks of life that I've known, from psychiatrists who are interested in addiction specialists, people from France, from people from Indiana. So all over have logged in to hear you guys opine about this. We don't have that many questions, but I'm going to start with a couple of questions. I was intrigued what you said, Alejandro, about the different frequencies, or maybe you both said it, are activating different receptors. Maybe that was Naveed's point there, activating different receptors on the dynorphin and the enkephalin level. Given that, what are the frequencies that you're using on the auricular stimulator to potentially activate all of them, or do you want to activate all of them? How are you developing your frequencies that you're actually using?
Yeah, that's a great question. I'll answer that real brief, and then Alejandro, please add to it. Yeah, so that study was actually something that really encouraged us when we started thinking about how do we help with pain mitigation and opioid withdrawal suppression. And so we have 2 channels, right, that we're targeting 2 different nerves. On the auricular branch of the vagus, we use a lower frequency respectively to the other. So we have about a 15 hertz pulse frequency that we're pushing through. And then on the trigeminal nerve, Alejandro spent a lot of time understanding trigeminal nerve stimulation, and we understand that it typically likes higher frequencies. And so we're putting about 100 hertz on that nerve. And so the idea is kind of looking at that 1992 study. Is this kind of dichotomous frequencies beneficial? Can we recruit more endogenous opioids and fill not only the mu receptor, which mostly is what pharma targets, but also can we look at kappa receptors and delta receptors and seeing if it can help with some of the depression outcomes of opioid use disorder and also pain mitigation?
I do wanted to add one small detail. It's not that we are activating the receptor itself. It is, again, I think it's very important to think about the network of multiple synapses along the way and how they resonate, if you want to bring up the analogy, going from electrical to electrical chemical, and how a particular frequency might allow you to have at the end of the chain a more powerful output, or another frequency might end up shutting down the system. So it's more of a systemic network that comes into play more so than the outcome. Of course, you see a different receptor being activated, but that is, there are many synapses along the way to get to that release of the enkephalins or the dynorphins or the beta endorphins. So that's a key point, I think, very important to make. And that will go for any other therapy when you want to activate or preferentially activate another network, right?
Exactly. That's a wonderful comment there. So one of the questions that have come in is there a role for heart rate variability to identify candidates with VNS? And I certainly have some thoughts on that, but I'll have you guys get started on that.
I can say a few words, and then Navid, of course. I would say, in principle, yes, but it's a very noisy measure, right? Because if the phone rings, it will change as you're. So it is. If you start thinking about your day or whatever, it will change. So it's a very noisy measurement. But if it's properly well controlled, yes, you can see the response. But it's a tough one. But yes, you can see it maybe in a long period. You can see overall getting better, but you need baselines here. So it's the answer. I would say yes, but it's a tough one to make a definitive answer, I would say.
Navid, do you want to add to that?
I think heart rate variability has been highly studied. I think there's a lot of use to looking at heart rate variability in terms of your biomarker for treatment, and then potentially looking for candidates. But I do think Alejandro makes a strong point, is that there is a lot of variability. So it's, from a clinical trial standpoint, it is difficult to design studies using heart rate variability as a strong endpoint. But clinically, there is use for it. It does make sense. Especially if you have patients that are on one spectrum of the scale and you show changes to heart rate variability. So but again, as we've seen with VNS and even the auricular applications, a lot of these changes are transient. And it's hard to really kind of hone in on what that means.
Yeah, I mean, part of the heart rate variability is you've described it kind of as a on-off switch, so to speak, but it's actually really, as the name suggests, beat to beat, it changes, and there can be an incredible amount of noise in the system. So my answer to that is definitely it's something that we should be looking at more aggressively. But the noise in the system with our current measurement tools makes it a difficult metric. Having said that, I think we will optimize our outcomes for clinical trials if we are using heart rate variability as one of our metrics. I think we'll be finding more answers there. So I think that's an interesting question there. I have a question for both of you here, and maybe it's a semantic question, but I've been thinking about this, particularly during your conversation today, is one of the focuses of Spark Biomedical is the treatment of addiction. But are you treating addiction or are you treating withdrawal?
Yeah, I'll go with that one. Yeah, we're treating withdrawal, right? So at least that was where we started. Our beachhead, as our other co-founder states, Dan Powell, we wanted to start with an area we knew that we had a strong signal in. And withdrawal is a very profound symptomological event, right? And so that was where we started, and we knew that was the first step. Anyone that wants to go through or to establish long-term recovery, the first step is going through opioid withdrawal. So yeah, so Peter, we started with opioid withdrawal, but now we are moving into more of a holistic approach in terms of the overall treatment of this patient. So to give you an idea of that, and I didn't talk about it in some of the other studies, but we're looking at relapse prevention and treatment retention and craving management, but we're also looking at the onset of dependency. So meaning for patients that go through a surgery and they have to use an opioid for pain mitigation, a lot of times, or not a lot of times, but in some cases, these patients become dependent and then they become severely addicted to this opiate. And so we're looking at how the device can help with reducing pain, which then can be opioid sparing, which then can be an OUD preventative. And so we're trying to understand from a full spectrum of how the device can be utilized, not for just withdrawal, but also kind of looking at the overall landscape of OUD.
Yeah, I think, you know, I'm one of the messages I'd like to make sure we get across is that any neuromodulation therapy that we're offering today is not intended to replace cognitive behavioral therapy and avoidance behaviors, et cetera. So it is important, and I don't think it's just the opioid receptor effect that you've described here. I also think that some of the tremendous benefits that you've described will be from autonomic changes that are occurring in the brain in the individual with addiction disorders. And you're going to be able to decrease the drive beyond the opioid receptor effect. So it's just it's an interesting semantic question, so to speak, because it's on the one hand, I'm believe deeply in our cognitive behavioral colleagues and the work that they're doing. This is intended to give you a tool or maybe a prosthesis to help you get through that window. But this is not a standalone therapy.
Correct. I would say that's very well said. We need to understand that to some degree, a dependency is a cognitive problem at the end of the day. I would like to say that because we are now focusing on the withdrawal, like Navid mentioned, but you do need to reconfigure the gain in the dopaminergic system, in the entire decision-making process or the reward mechanism, in order for you to make decisions with a more using the prefrontal cortex more than the amygdala, and I think that takes time. That rewiring takes a long time, and of course, a short period of time is only to let you go through the withdrawal. And as Navid mentioned, we are looking into longer periods of time, as we show. There are some trials talking about the cognitive effect, and it will be an adjunctive therapy. You still need somebody to help you go through this period, but it could help with that rewiring, the cognitive aspect of the problem also. But definitely you need other people involved in this. This is not a magic bullet where you put it and you're done. Definitely not.
Great, thank you for that. So I think we're going to take our last question from what I believe is 3 a.m, where this person is writing from. So speak slowly. The question is there a circadian effect on tAVNS, and what time of day is better to use it?
That's a great question. We haven't studied it properly, to be honest. Theoretically, there is likely some effect because, of course, many of the things that we're pushing, that we're forcing, they will have an underlying circadian rhythm. But I'm not sure if it is that prevalent or that significant. We do know, and Navid can talk about it more, we do know that patients can go through the night after using it for a very long time. Patients can go through the night without using it. I don't know what that means yet. If that once you settle into your night mode after a long period of therapy, 12 hours or so, maybe the autonomics are a little better, and it allows you to go without it. But I would think that it will highly be dependent on what you're trying to target. Cognitive, behavior, the addiction aspect. So I am not sure that there will be an answer for all therapies. Now that I'm thinking about it as we speak about it, probably different times of day might actually be better for different aspects of this therapy. How much better? I don't know if it'll be significant to the clinical, clinical relevance, but scientifically there might be some differences. Yes.
The only thing I would add on to that is, I think kind of where that question may be coming from is how autonomics change throughout the day, right? And so, your autonomics when you wake up are very different than when you go to bed. And they're very different when you're getting hungry for dinner. And, and then as you go to bed, when you're sleeping, your autonomics are obviously very different than when you are awake, right? And I wear a wellness tracker on myself, and I see my HRV changing as I'm sleeping versus when I'm awake. So I know in my case, that's true. So now whether you target specific windows of these phases, right, it is a great question. And, but I also think it matters on the indication. It may be beneficial for certain indications, for example, for learning and memory. There's evidence to state that you should deliver vagus nerve stimulation while you sleep for memory consolidation. That may not be the case for someone that's experiencing, chronic pain or another type of psychological disorder. So, yeah, it's a great question.
Yeah, and unfortunately, we have many more coming in, but I'm going to have to call it for the evening. You guys have been very generous with your time tonight. Thank you very much. Thank you all for listening in to this webinar. We will, if you have friends who missed this, we will get this up on the website at one point. It takes a few weeks to get this edited down, but we'll have something up for you at some point in the near future. So for those of you who are not members of the Vagus Nerve Society, go to vnsociety.org. Thank you, Navid. Thank you, Alejandro. It was an absolute pleasure to be with you guys tonight.
Thank you, Peter.
Thank you very much.